Hello and welcome. The liver is the largest solid organ in the body and is responsible for many vital functions, including the synthesis of essential proteins, clearing toxins from the body, and metabolism of carbohydrates, fats, and cholesterol. Liver disorders are prevalent, and cirrhosis is presently the 12th leading cause of death in the United States. Imagine you have a patient with a history of advanced liver disease who you are evaluating, perhaps at time of hospital admission or prior to surgery or perhaps in the emergency room. How will your evaluation of this patient differ from that of most other patients? In this video, I am going to share with you an approach I use when evaluating the patient with cirrhosis or other liver disorders. I also use this approach when presenting a clinical case, as it organizes important information in a way that I can easily remember. This video is directed toward medical professionals. My goal is not to really teach you anything new, rather my goal is to help you organize what you hopefully already know while you're evaluating and managing patients with liver disorders. As you see, I have titled this The ABCs of Evaluating the Patient with Liver Disease. A is for albumin. Albumin is the major plasma protein produced by the liver, and hypoalbuminemia is a bellwether of disease. Low plasma albumin levels are indicative of either decreased hepatic production or increased loss. Albumin may be lost by the kidneys, nephrotic syndrome, or via the GI tract, for example, protein-losing enteropathy. Hypoalbuminemia that is caused by decreased hepatic synthesis is often associated with irreversible liver disease and advanced cirrhosis. Many hormones bind to albumin, for example, thyroxine, cortisol, and testosterone. Calcium also binds to albumin. Their function will be variously affected by low plasma albumin levels. Many drugs are also bound in the circulation to albumin, and drug effects may be exaggerated if the dosage is not appropriately reduced in hypoalbuminemic patients. Albumin plays an important role in maintaining normal plasma oncotic pressure, and low albumin levels may lead to excessive fluid leaving capillaries and to formation of edema and ascites. Determining plasma albumin level is essential in assessing the patient with liver disease. B is for bleeding. Blood from the splenic vein, superior mesenteric vein, and inferior mesenteric vein flows through the portal vein. Patients with portal hypertension are at risk of GI bleeding, especially from esophageal varices. These patients may also bleed from the stomach as well as from other portions of the GI tract. Assessment of risk of bleeding is important in medical management of patients with portal hypertension and liver failure. There are certain medications, for example beta blockers, and other preventative treatments such as TIPS procedure or endoscopic variceal ligation that may be used to prevent bleeding. B is also for bilirubin. Bilirubin is normally produced during red blood cell catabolism. The liver clears bilirubin from the body, and elevated bilirubin levels may be associated with moderate or severe liver failure. Importantly, elevated levels of bilirubin have also been shown to be an indicator of severity of disease in patients with liver failure. Total bilirubin should therefore also be determined when evaluating patients with cirrhosis. C is for creatinine and coags. Creatinine is an important indicator of kidney health. In patients with cirrhosis, there is a syndrome known as hepatorenal syndrome, where kidney function may diminish as hepatic function diminishes. Like serum bilirubin levels, elevated serum creatinine levels have also been shown to be an indicator of severity of disease and mortality risk in patients with liver disease. Besides creatinine, coags should also be evaluated in cirrhotic patients. The liver is responsible for making most coagulation factors. In end-stage liver disease, the lack of production of essential coagulation factors impairs the ability of blood to form clots. Therefore, abnormal coagulation profiles are also commonly found in patients with liver disorders. I recommend monitoring PT, PTT, INR, and fibrinogen. In patients who've been on hemodialysis more than once per week, and who are scheduled to have a major surgical procedure, I also recommend monitoring levels of antithrombin and correcting low antithrombin levels prior to surgery. Platelets are also essential for the formation of blood clots. Cirrhosis and portal hypertension may also lead to splenomegaly and sequestration of platelets in the spleen. Therefore, besides checking levels of coagulation factors, platelet count is also essential to determine in patients with portal hypertension. D is for drugs. Drug therapy should be carefully tailored to these patients. The liver is responsible for metabolizing many drugs, so the half-life of many drugs will be elevated in patients with liver disease. Because of the prolonged duration of effect, the dosing interval of many drugs should be increased to avoid toxic blood levels. Also, for drugs that are highly protein-bound, the free fraction of drug may be increased in patients with low levels of albumin and other serum proteins. Drug toxicity is therefore often much more likely in patients with cirrhosis. Drugs that undergo oxidative metabolism in the liver are more susceptible to the effects of cirrhosis than are other drugs. For example, oxazepam and lorazepam are two benzodiazepines that are metabolized by glucuronidation. These two benzodiazepines have a much more predictable metabolism in cirrhotic patients than other benzodiazepines. Consequently, if you have decided to treat a patient with alcoholic cirrhosis at risk of DTs with a benzodiazepine, lorazepam is a much better choice than either diazepam or chlordiazepoxide, Librium, because of its more predictable non-oxidative metabolism. Another point is that since many patients with end-stage liver disease have some degrees of hepatic encephalopathy, care should also be taken when administering narcotics and other CNS depressants to these patients. E is for electrolytes. Patients with advanced liver disease are predisposed to have electrolyte abnormalities. Hypoalbuminemia and portal hypertension may predispose patients to hyponatremia. In patients with cirrhosis and ascites, serum sodium levels below 130 millimoles per liter should be treated. Hyponatremia is also associated with increased rate of complications and mortality in cirrhosis. Hyponatremia management is a bit controversial, but often involves fluid restriction or diuretics. Aldosterone is a mineralocorticoid steroid hormone produced in the adrenal gland and responsible for retaining sodium in water while eliminating potassium from the body. Aldosterone is cleared from the body by the liver, so individuals with liver disease often have elevated aldosterone levels. When evaluating the patient with liver disease, you should assess serum sodium and potassium levels and also consider total body water status. Spironolactone aldactone, a potassium-sparing diuretic, is an aldosterone receptor antagonist and is often indicated to treat fluid and electrolyte abnormalities in cirrhotic patients with elevated aldosterone levels. F is for fluids. Many cirrhotic patients should be managed with fluid restrictions. Others, such as patients with hypoalbuminemia or hyponatremia, may require albumin or administration of fresh frozen plasma, FFP. Untreated low plasma oncotic pressure may aggravate ascites and edema, including pulmonary edema. FFP, cryoprecipitate, and platelets may be indicated for patients with abnormal coagulation profiles who are bleeding or at risk of bleeding. And of course, red blood cells may be necessary for surgical patients or patients with active GI bleeding. As you assess a patient with advanced liver disease, you should carefully consider your plan for fluid management. And finally, G is for glucose. The liver is important for many metabolic processes, including storing and mobilizing glycogen. About 30% of patients with cirrhosis have diabetes. Therefore, glucose levels should be monitored in patients with advanced liver disease. This summarizes my approach to evaluating patients with liver disorders. I hope you have found this helpful. Please leave questions, suggestions, and comments below. And if you would like to support this content, please subscribe to this channel and give this video a like. Thank you.